So let me share the screen.
Yeah, I think we have gone live on YouTube now.
Okay. Srinath, admit all. Ashok, we are live. Ashok, can we start? Rudra, you can share your screen. Unmute yourself.
I'm trying, but showing you cannot start screen share while the other participant is sharing.
I have stopped sharing. You can share now.
No, sir, still showing. Still showing your screen, sir.
My screen?
Yes, sir.
I think now you can go.
Yes, sir.
Great. Ashok, we are live. Okay. Good evening, everyone, and welcome back again to one more episode of TMH Orthonco classes. Today's class is about reconstruction of bony defects, and we in particular gonna address the biological reconstructions. Dr. Rudra Pratap Singh Thakur is the presenter. I'm going to moderate the session as usual, and we have our external faculty, Dr. Yogesh Panchwag, also with us, and few more are expected to join. So, Rudra, over to you.
Thank you, sir. Am I audible, sir?
Yeah.
Yeah. Good evening, everyone. Greetings from Tata Memorial Hospital. So the topic of today's presentation is biological reconstruction after tumor excision. So this is the basic layout of the presentation, in which we will be going through the reconstruction options after a tumor excision. We'll be having a look at the biological reconstruction and also its advantages and disadvantages. We are going to have a brief overview of its classification. We'll be discussing biological reconstruction after curettage of a lesion and also after resection defects of a bony tumor. We'll discuss the individual reconstruction options, its advantages and disadvantages on the basis of their anatomical location. In the last, we'll have a brief review of the factors that decide the choice of reconstruction in a patient. So to start with, in the last few sessions, we have already seen that with the development of neoadjuvant chemotherapy, newer imaging modality, and newer surgical techniques, we have gradually shifted from LBT procedures for tumor surgery like hip disarticulation or amputations to now limb salvage. Usually, these resections are left over with huge bony defects, and the defects require reconstruction. The bony defect, that is, if it is small or if the bone that has been excised is expendable, then no reconstruction is required. But if the defect is large or it leads to a huge functional disability in a patient, then it will require reconstruction. The reconstruction options can be broadly divided into two parts. It can be either biological or a non-biological one. The most commonly used non-biological reconstruction options are megaprosthesis and nail cement or a plate cement spacer. And biological reconstruction options are broadly divided into viable bone material and non-viable bone materials. So these are the two examples in which a tumor excision is not followed by a reconstruction. First is a proximal fibula osteosarcoma, and second is a osteosarcoma of the proximal radius, which have been excised and no reconstruction has been done afterwards. So biological reconstruction is a technique which utilizes either patient's own tissue or an allograft to reconstruct the defect. The advantage of this technique is first is no revisions are required. And second, it's an economical procedure. The disadvantage of the procedure, it is time consuming, it is technically difficult to do and learn. These reconstruction have delayed rehabilitation, and they are affected by adjuvant therapies like chemotherapy and radiotherapy. So this is brief classification of the biological reconstruction option. First is those utilizing the viable bone materials. In that comes the vascularized fibular graft, a vascularized iliac bone graft, and formation of new bone with the help of distraction osteogenesis using Lazaro fixator. Non-viable bone materials use allograft or patient's own tumor bone sterilized and put back with one of the below mentioned modality. So we have already discussed in the past classes that there are different margins for excision of a tumor. It can be interlesional, marginal, wide, or a radical one. It differs from pathology and bone. For a benign lesion like a ABC, chondroblastoma, or a giant cell tumor, we go for an extended curettage. The bony defect then left is either filled left as such if it is small, and or it is filled with a filler, which can be either cement or a bone graft. Bone grafts are the biological options to reconstruct these defects, and they are further comprises of either an allograft or an autograft. So this is a lesion of the proximal humerus. It's a chondroblastoma. We treated with a extended curettage and allografting. This is a long-term follow-up with the patient, and it shows good incorporation of the graft inside the tumor bone, inside the bone. Second examples of the distal femur and proximal tibia chondroblastomas, which can again be treated with extended curettage and allografting. Both shows good incorporation of graft into the host bone. A special type of technique again described for reconstruction of defects around knee joint, which utilizes both bone graft as well as cement. A bone graft is placed just below the articular surface if a small amount of bone is left below the articular surface, and it is separated from a cement with the help of a gel foam in order to prevent the damage to the articular cartilage, which happens because of the cement setting heat that is generated during cement setting. So advantages of bone graft are the remodeling. It has remodeling along the stress lines. Reconstruction obtained is permanent. Disadvantages include the autograft quantity is limited. Donor-sided morbidity is there. Allograft requires a bone bank, which is not usually available everywhere, and the recurrence are relatively difficult to spot in case of a bone graft. Umbrella construct is a special type of autograft reconstruction technique which we utilize in case of a proximal femur. In this, we use a allograft femoral head, which is denuded with this articular cartilage and then placed inside the hollow of the proximal humerus. It is then supported with a strut graft from either radius, fibula, or a metatarsal strut. And these grafts are then fixed with the help of K-wires. This is the long-term follow-up of a patient we treated with umbrella construct, and you can see the good abduction and flexion in this patient. Here's the video of the same patient, which shows good range of motion around the shoulder joint. You can't differentiate which side has been operated in this case. So in our study from TMH of 11 cases, we found that 10 out of 11 graft united at a mean period of 7 months. And we observed a mean musculoskeletal tumor society score of 27 in our patients. Only one patient had a graft fracture. Now discussing about the resection options in resection defects.
Rudra, we will stop here. We will stop here. Okay. Yeah. So just go back. Go back one slide. Okay. So no, that's okay. You can. So essentially, this talk was about reconstruction of bony defects by biological methods of reconstructions. Usually, the defects after curettage are not covered, but we thought that if for the orthopedic residents or other MCS residents, it will be good to address the curettage defects also in this question. And obviously, a lot of general orthopedic surgeons also talk about reconstructing these curated defects with biological reconstruction. That's why we have included the biological reconstruction of curated graft in this talk. So I think we'll take a few questions here, and we will ask Dr. Panchwag. Dr. Panchwag, we all know that curettage for benign aggressive lesions is the preferred modality of treatment. And when we do extended curettage, most of these defects are either filled by a biological method, which is by using bone, whether it is a strut graft or a morselized graft, whether it's allograft or autograft, or it is done by cement. So what is your method of choice, and how do you choose a patient whether which type of filler is suitable for that patient? I think that will be very helpful for everyone.
Yeah, okay, Ashish. So there are multiple factors which decides what sort of a reconstruction we are going to do after a curettage. First and foremost, what is the patient's perspective? What sort of rehabilitation program he would like to undergo? Whether he would like to have a very quick return to his activities of daily living, or whether he can sort of give a certain time, or he can spend a lot of time, or rather 6 to 8 weeks at least, on a non-weight bearing type of protocol during the rehabilitation. Whether he or she is willing to sort of undergo a second site surgery, like getting the autograft harvested and using that in the defect. Not everyone has an access to allografts, and not every institute has a bone bank. So most of the times when we are talking of a biological reconstruction, it is the autograft from the iliac crest or a fibular graft that we are talking about. So that is one factor. Another factor is the size of the defect, the volume of the defect that is going to be resulting. Whether we can really have that much amount of autograft or allograft that we can insert in the defect. That is one factor. Another factor is how much of a subchondral bone is remaining behind. Whether if we have more than say 4 to 5 millimeters or so of subchondral bone after the extended curettage is done, then the choice is left to the surgeon. It can be filled up either with cement or bone graft, whatever is the choice. If it's less than 5 millimeters, then we would typically choose to have some subchondral bone over there, and we may use either an iliac crest strut graft or a morselized graft, and then pack the rest of the cavity with either bone or cement, whatever the case may be. And the more critical factor, I feel, is the state of the articular cartilage of the joint that we are joint near which we are operating. What sort of an condition that articular cartilage is in decides most of the times what type of reconstruction we are going to do. So if we have a good thick or non-pliable cartilage that is being left behind and which just needs to be supported, then it could be either a sandwich type of a reconstruction. But if you are looking at a very flimsy, very thinned out articular cartilage, which is kind of like a very thin ping pong ball kind of an appearance, then it's better to be supplemented with filling the cavity with cement, because that will give a good amount of stability, structural stability to reconstruct. The complication of articular cartilage degeneration because of exothermic reaction while the cement sets, it's not really very well proven in the literature. So we have to have more analysis on our cases as far as that is concerned. And whether to supplement that with any sort of internal fixation will again depend upon the size of the defect. So yes, if it's more than 50% of the end of the bone that is involved, then we would typically end up supplementing with some sort of an internal fixation. So these are the multiple factors that decide actually what sort of reconstruction.
Yeah, thanks a lot for very detailed elaboration on how you choose the filler material depending upon the age, the site, the remnant curated cavity, and obviously the rehab protocol. I would like to ask a few very quick questions and quick answers. Is that do you feel that morselized grafts are better or struts grafts are better if they are available?
I personally prefer strut grafts because of the mechanical strength that they offer. Morselized grafts, typically, if the cartilage is not very stiff, they will tend to sort of collapse and lead to an articular cartilage or joint degeneration and early osteoarthritic changes. That is what we have experienced. So whenever possible, if feasible, we try to use tricortical grafts for support.
Many people ask question, is it really necessary to fill the whole cavity, or you may leave some spaces in between if you are putting like struts graft?
Yeah, so in a strut graft, we don't have to fill the entire cavity. We have ample experience now, which when we have put in fibula struts or iliac crest struts and just sort of taken care of the basic reconstruct, we have seen that the rest of the cavity fills up with bone later on as during the follow-up over the next maybe 1.5 years. So filling the cavity entirely is not required with bone.
Thank you, sir. Thank you very much. So we had this nice discussion on, so we have covered the questions about filling the curated cavity with biological methods of reconstruction. And now Rudra will speak to us that if we have resection of a tumor, a resection of the bone and the remnant defect, how do we fill that? Rudra.
So we are now going to discuss the resection option, reconstruction option after a resection defect. So resections are basically classified into two types in a long bone. It can be either an osteoarticular involving a part of the joint, or it can be intercalary. For osteoarticular resections, the two options that are available are either arthroplasty or arthrodesis. In arthroplasty, we can go for a live fibula as we go for a proximal humerus, or an osteoarticular allograft. In arthrodesis, we can either use a Ilizarov to achieve arthrodesis of a joint, or with the help of an allograft using an interlocking nail or a plate. Osteoarticular reconstruction can also be done with the help of patient's own tumor bone sterilized and put back, but usually they are supplemented with a surface replacement. So intercalary resections are reconstructed with either bone graft, which can be an autograft or a combination of auto and allograft, or by using patient's own tumor bone with the sterilized with one of the below mentioned modality. So discussing about the upper limb, first, here's a case of an osteosarcoma of the proximal humerus, for which we did a wide excision in a plate cement spacer. These type of non-biological reconstruction options are, as we know, are not particular and are susceptible to wear and tear. So this plate broke off. Later on, we removed the implant and cement and reconstructed with the help of an epiphyseal live fibular, free fibular graft. So coming to the distal radius part, the recessions option in a distal radius resection depends on the resection length. If the resection length is around 4 to 5 centimeters, the defect can be filled with the help of iliac crest and arthrodesis can be done. If the resection length is less than 8 centimeter, the adjacent ulna can be translocated into the defect and can be filled with that. And if the resection length is more than 8 centimeter, the whole of the distal carpus can be transferred and ulnar centralization can be done, or a vascularized fibula graft can be done for the reconstruction. So first of all, we will be discussing the arthrodesis of the wrist joint with the help of iliac bone graft. If a defect is less than is around 4 to 5 centimeter, then a iliac crest is harvested and shaped according to the defect. This graft is then used to fill up the defect, and wrist joint is arthrodesed in about 10 to 15 degree of dorsiflexion with the help of a plate. The advantages of this technique is that it leaves no cosmetic deformity as both bones are present in the forearm, and it preserves pronation and supination. But the disadvantage is that it has a donor side morbidity, and by doing this, we lose wrist range of motion. We published our study of 12 patients in which we found out grip strength was 69% of the non-operated as compared to the non-operated limb, and mean arc of rotation was about 126 degree. The mean musculoskeletal tumor society score we observed was 25. And then a study by Wang et al. Of 39 patients, the mean grip strength was found to be 51%, and the mean arc of forearm rotation they found was 113 degrees. So second option is ulnar translocation. This is the first example of a body bone transfer in which a segment of the limb in which two bones are present. One bone can be used to fill up the defect of the other. So in ulnar translocation, if the defect is less than 8 centimeter, the adjacent ulna can be transferred into the defect, cutting preserving its soft tissue attachment but cutting complete periosteum, and then the wrist arthrodesis can be done. The advantage of this procedure is that it preserves pronation and supination, and it facilitates skin closure in case if there lots of skin is lost while doing the resection. As there will be only one bone in the forearm, so closure is easy. The disadvantage of this procedure is that it leads to a cosmetic deformity, a thinner forearm, and is also there is a loss of wrist range of motion. So here's a video of a patient in which we did an ulnar translocation, showing good pronation and supination, almost complete. In our study of 14 patients, we found mean resection length of 7.9 centimeter, and all except one patient had a good range of motion. The mean MSTS score we found was 26 in our study. The third option that comes is of ulnar centralization if the defect is more than 8 centimeter. So in this, after excision, we centralize the whole of the distal limb, from the carpus, and we fuse the joint. So it's centralized over the ulna, and then we fuse the joint. The advantage of this procedure is that it has no graft site morbidity and it's stable. But the disadvantage is that there is cosmetic deformity of a thinner forearm, and there is complete loss of pronation, supination, as well as reduced range of motion. The fourth option for reconstruction of distal radius defect is free fibula. The advantage of this procedure is that it provides mobility, but the disadvantage is that it leads to a donor side morbidity like a foot draw, and it can also lead to a later instability and wrist pain in the later life. So these are the few studies which show their incidences of subluxations of wrist joint after a free fibula and subsequent pain full joint, showing about 10 out of 24 and 4 out of 13 and 3 out of 12 incidents. Coming to the lower limb, after an osteoarticular resection of the lower limb, the first option that we can do is
I will stop here for a minute because a lot of people ask question. If you can go back to the slide where you are showing the algorithm for distal radius, it will be nice because a lot of people have a lot of doubts and they ask these questions about that there are multiple options. Yeah, there are multiple options available for reconstruction of distal radial defect. So in Tata Memorial Hospital, we have made very nice guidelines on which we can take decisions that which option do we follow. So if you are resecting a distal radius and you want to maintain supination pronation, then you have to reconstruct the line which joins the remnant radius to the carpus with a bone graft. So that's essentially the principle. Now, there are many times when this radius defect is very big and only a small part of proximal radius is remaining. or you lose a lot of muscles and motors are not adequate, then you do something called as centralization of carpus over the ulna. Now, disadvantages of carpus centralization is that you cannot have supination and pronation in these patients. Now, Rudra has written RL 8 centimeters. I think that is very sort of subjective, depending upon what is the forearm length. So that cannot be taken as a ballpark figure. Then remains the smaller defects. So defects up to 5 or maximum 6 centimeters, you can reconstruct with the help of iliac crust graft. So, and other option which is available is to do the translocation of ulna, as example is shown by Rudra. Now, the advantages of doing iliac crust is that the width of the wrist is maintained, but it is technically challenging. Over a period of time, we have refined our technique and we are in the process of publishing it. The graft has to be thin, the ulnar variance has to be really checked. So you need a bit of sort of learning curve in this technique if you want to have good results and good cosmesis. Otherwise, our age-old technique of ulnar translocation, which again Rudra showed you, fantastic results of ulnar translocation. Now this patient where Rudra showed the video, actually he is a 10-year follow-up of ulnar translocation. So that has stood the test of the time and give us fantastic results. A few of my colleagues also prefer doing a fibular arthroplasty, but we TMH do not have great experience with that. But what I know is that if it is not done properly with the formation of the tendon and fascial slings, the rate of osteoarthritis at the wrist, subluxation, and rate of revision surgery is extremely high. So we need to be a bit wary about. So this is the way how we take decision on how do we reconstruct the distal radius defect the best. Dr. Panchwal, any different views on this or any views on fibular arthroplasty?
Yeah, so as far as using the proximal ipsilateral fibula to reconstruct the joint, it's going to work well only if you are able to reconstruct the capsuloligamentous structures really very well around the wrist joint. That is what is going to maintain the stability of the wrist joint at the later date and prevent subluxation and wrist stiffness and pain that results because of this particular subluxation. Now, if you consider the cases where you are going to have a good capsuloligamentous structure remaining behind after doing the resection, are probably those cases where you would have not done a resection, where you would have got away well with intralesional curettage and reconstruction in the distal radius as well. So I feel that in cases of the distal radius GCT where you're going to resect, these are basically big Capanna grade 3 lesions where you don't have a good capsuloligamentous structure which is left behind for a good kind of a arthroplasty reconstruction to be and a good functional result to be achieved. So I feel that a proximal fibular arthroplasty is probably not a very good idea, and because these particular cases do require a stable fused wrist, which will give a very good function, stable wrist, painless wrist, and obviously does not have a lot of functional disability as well.
Thank you, sir. Rudra, back to you.
So we'll be discussing now the reconstruction of in a lower limb resections. For the osteoarticular resection of the around knee joint, we can either arthrotize the joint with the help of a plate or a nail or using a Lizaro fixator. So this is the video of a patient which shows good mobility after that. The drawback of the procedure is that there is no linear motion, but there is a stable joint. So this type of reconstruction is prevalent in the patients which require which are heavy workers and manual laborers. The second type of reconstruction after an osteoarticular resection around knee joint can be osteoarticular allograft, but the results are not very promising. 70% of the patient in the studies have experienced to have fracture or arthritis or non-union infection, and 60% of these allografts needed to be removed after 5 years. So in intercalary resections, there are two types of resections. It can be either diaphyseal or a metaphysio-diaphyseal. The most common graft that we use to reconstruct is the fibular allograft. It can be used either as a osteocutaneous or a osseous free flap, or a pedicle tibialization, or as a non-vascular flap. It can be used as a free single strut bone or a double barrel fashion. It can be used from diaphysis or can be harvested as an epimetaphyseal graft. A maximum of 30 centimeter can be harvested from fibula. So here is a patient of wing sarcoma of humerus with a pathological fracture, which we have reconstructed with a free fibula and fixation, and long-term outcome shows good union at the proximal and the distal aspect of the joint. Similarly, osteosarcoma of the diaphysis of the radius, which has been treated with intercalary resection and reconstruction with free fibula, and at 2 years of follow-up, we can see a good union in proximal distal aspect of the joint. The problem with this kind of graft is that they are a thin bone and they take a long time to get incorporated, and there are chances of fracture in this. So these are the outcomes from memorial screen catering, and a study by Harry et al. Which shows good outcome. In 25 of the patient in memorial stone catering, they found that all of the flaps survived. And in the other study, 38 out of 38 patients, bony unions were achieved in 89% of them, and mean MSJ score was 27.2. So to counteract the problem of weakness of the graft, these grafts can be used in combination with allograft. A strut allograft is used with a vascularized fibula. The fibula is placed coaxially inside an allograft, leaving the pedicle behind, which can be later anastomored with the local bed. The advantages of this Capanna technique is that it provides additional structural stability, and it also improves the chances of incorporation of the allograft. So the study by Capanna et al., they saw 25 patients in which only 3 of them failed. And the fibula was united in the mean duration of 5.6 months, and allograft united at the mean of 19.6 months. The total limb salvage rate in their study by using this technique was about 88%. The second technique by which a fibula can be used to reconstruct a defect is another example of buddy bone, in which this fibula can be transferred in the defect of the tibia. Fibula can be transferred in the defect of tibia and fill the defect. It can be either used for an intercalary resection or can be used for an osteoarticular resection of the distal tibia. Transfer has the advantage that it's vascularized and offers an easy closure as there is a single bone leg. And disadvantages of the procedure is that it has a chances of graft fracture and chances of malunion are always there. So here is an example of a weaving sarcoma of the tibia in which intercalary resection has been done. Both proximal and distal osteotomy site has been divided. The fibula is gradually picking up the thickness of the tibia. Here is another example of intercalary resection in which the fibula has almost taken up the width of the tibial host bone. The debilitation of fibula can also be done for an osteoarticular defect. In this study, in this patient, we have done a arthrodesis of the ankle joint with the help of a osteoarticular fibula debilitation. So free fibula can also be used as a single bone or in a double barrel technique to provide increased structural stability. It can be used around knee joint as well as around the ankle joint for reconstruction. The second option that comes for reconstruction and intercalary resection is using the patient's tumor own bone.
Rudra, we'll stop here. Okay, so this was the another half of the reconstructing the defects with biological methods of reconstruction. And I think there are a few very pertaining questions here which we need to address. And I would like to have comment from Dr. Panchwag. Dr. Panchwag has vast experience where he has seen during his training in Europe, where he has seen osteoarticular reconstructions with allograft, and he has also witnessed a lot of Capanna technique. So, Dr. Panchwag, first question to you is that we know that in India, we do not have a lot of osteoarticular allografts available. But what has been your experience while you were in Europe and when you have traveled to other centers which use osteoarticular allografts? Is it really worth to try? And what are the requirements or cost implications for this technique?
Yeah, basically osteoarticular allograft is one of the options which is done in centers which have very good bone banks, and where the national policy is to have an cadaveric bone donation program. So this has been put effectively into use only in a few countries, Italy being one, and the other one is Argentina. So these are the nations where these particular type of reconstructions are more commonly done, because they have a very aggressive cadaveric bone donation program and excellent bone bank facilities. Now, what they do is that they have age matched and size matched bone bank allografts which they use for these type of reconstructions. And most of the times they will be resurfacing the joint. If it's the joint that's going to be resected, then they will be resurfacing that particular joint involved and use something called as an allograft processes composite for doing the reconstruction. Around the knee and around the hip, it's a bad idea to do only an osteoarticular allograft purely without any resurfacing modality. So that's not what these particular centers follow. So I have seen an pelvic allograft being used, and proximal femur being used, a distal femur and a proximal tibia being used, but that is not what we do in India. As far as the allograft is concerned, a few centers in India have started doing ECRTs and fixing it back, typically in the pelvis. But as far as the knee and the hip is concerned, I don't think that we can get away with a pure osteoarticular allograft kind of a reconstruction.
Thank you, Dr. Panchwag, about a great detail about osteoarticular. Now, second question is regarding the Capanna's technique. You have witnessed Capanna's technique right in the centers where it was devised, and we all use it here. So a few tips or learning points how to do this Capanna techniques correctly, because this is considered as the best possible reconstruction, the biological method of reconstruction for a defect. So how do
Yeah.
you do it? What are learning points which you have taken from Italy, looking at Capanna himself?
So basically, as you rightly pointed out, it's one of the best sort of a reconstruction options that is available, which combines the biological as well as the non-biological reconstructive options. It gives an immediate structural stability and also adds an vascular bone graft to that kind of a reconstruct. And in Italy, we have had cities where they have analyzed CT scans of the patients, and especially the kids who were operated in their early childhood. And we have seen that the fibula slowly hypertrophies and actually replaces the dead bone around it. So we have had beautiful, sort of series which has shown that the combination of allograft with vascularized fibula works fantastically well. As far as the technique is concerned, we have to be, sure that obviously the disease clearance is not to be compromised upon. Capanna has now modified the kind of the slide that we see on the screen currently shows that a slot has been entirely made. That is typically done when the fibula is very big in size, and that is inserted so that you're not stripping of the periosteum, you're not stripping of the blood vessel or the fibular nutrient artery that is supplying vascularity to the fibula. However, now Capanna, in certain cases where it's feasible, he has modified the technique by using only a small window in the radiated graft or the allograft, and they bring out that particular nutrient feeder vessel through that particular fenestration or the window, and the rest of the graft is intact all around. So a complete slot is not made. But this is not possible in all the cases. This is possible only when the allograft canal, medullary canal, is big in size and the fibula is very small in size, so as to not strip up the vascularity and the periosteum from this fibula. Well, you need to have a very good microvascular team operating along with you. What we do is that to save time, we start operating simultaneously. So when I'm operating on the resection, my plastic surgeon will start harvesting the fibula, and during the same time that I have finished resection, he's finished harvesting the fibula, and we sort of start, as we send the graft for ECRT, we start preparing the bed for fixation, and by the time the bone is back, the nutrient, the recipient vessel, the donor vessels, everything are kept ready. The bone is the fibula is not resected completely, so we try to reduce the vascular time for the fibula as much as possible. So when the radiated bone is back in the OT and when we have prepared it for reimplantation, at the last minute we sort of dissect out the vessels that of the fibula from the donor side, and then we use a very fresh vascularized fibula to be inserted into the allograft. So that is one tip where we sort of reduce the vascular time, or rather the fibula blood supply keeps on running or keeps on going on till the very last minute. Yes, and depending on the skills of the microvascular surgeon, a very fast reconstruction should be done in about 10 to 15 minutes each for the vein and the artery, depending on how many veins and arteries you want to reconstruct or anastomose.
Great, Dr. Panchwag. And yeah, so in TMH also we do the same thing. We have two teams, the plastic surgery team and the resecting team. Usually we take the fibula from the opposite side because it's easier to operate. And Dr. Panchwag has very beautifully explained the Capanna techniques and fine tips for the surgeons how to do it correctly. The only thing which I would like to add is that we take a lot of time in the planning of these cases. We plan the resection length and we talk to the plastic team well in advance, tell them the requirement, because you require a couple of centimeters going into the each side of the host bone. So we ask for a bit longer fibula. Sometimes we try to, if possible, we try to avoid harvesting the proximal end, because we have seen then that the rate of neuropraxia or neural injury to the common peroneal nerve increases if you are trying to harvest the upper end. So we try to harvest the middle segment. Obviously, you need to leave 6 centimeters of distal fibula to maintain the integrity and the stability of the ankle joint. So depending on that, we do a lot of pre-operative planning and we talk to our team so that intraoperatively we have less confusions. Everybody is updated about what's the plan, and I think things runs pretty smooth that way. Okay, great. Rudra, please go ahead.
So other kind of reconstruction that we can do after enterocari resection is by using patient's own tumor bone, which has been obtained after resection. This tumor bone can be stripped out from all the soft tissue and then can be sterilized with either radiotherapy, liquid nitrogen, pasteurization, autoclaving, or microwave. After this sterilized bone act as a size match allograft for the patient and can be used to reconstruct the defect. But the problems with this is that they can be done in an already damaged bone, like if the bone is eaten up by the disease itself or if there is a pathological fracture. And the second limitation is that radiotherapy can't be given as an adjuvant afterwards, which will inhibit the incorporation of this segment into the host bone. So first of all, which is the most common one used for the sterilization, is using the radiation, also causes the ECRT or the extracorporeal radiotherapy. In this, following all the oncological principles, we first excise the specimen, and the specimen is denuded from its soft tissue attachment, including the soft tissue component of the tumor. This procedure is done in a separate table, taking precaution that the operative field or the rest of the instrument should not get contaminated with the tumor cells. After stripping from the soft tissue, this specimen is now wrapped up in a vancomycin soaked mop, and then it is packed up in a sterile plastic sheet. This specimen is now placed in a sterile ECRT box, and then a single cycle of 50 gray is being administered to the specimen. By this time, we prepare the bed for reimplantation and achieve hemostasis. Till that time, after coming from radiation, the specimen is kept submerged in a vancomycin saline solution, and then it is washed with a pulse lavage to clear the debris. This is the case of Ewing sarcoma of the femur, in which we have done an enterocari resection, and we have done a ECRT of the bone and reimplanted it back. You can see on the ends we have place morselized bone graft to augment the union of the excised specimen. So this is the long term of the follow of the patient. We can see good union in the both proximal and distal osteotomy sites. This is another patient of osteosarcoma of the ulna in which intercalary resection has been done, avoiding the joint line. It has been fixed with tension varying intramedullary nail and a plate on the distal osteotomy side. The image shows a good union in both proximal and distal side. This is the video of the same patient showing a scar and good elbow range of motion in both flexion extension and pronation supination. So in a study of about 70 patients, we found out that about 91% of the metaphyseal osteotomy is united and 71% of diaphyseal osteotomy is united. Adding a small plate at the diaphyseal osteotomy apparently reduced incidence of non-union from 31 to 17%. Addition of the morselized allograft did not help in union. The 5-year survival of the ECRT graft was found to be 79%. In 7 patients, we observed a local recurrence, but all these recurrences were in soft tissue, not arising from the irradiated bone. Another example of avian sarcoma of the humerus with a skip mat in the proximal aspect. We have done a ECRT for an osteoarticular resection. It can be done for osteoarticular resection as well. This is the long-term good follow-up of the same of the patient. So the problem with this technique is there can be non-union or a fracture at the graft site. It has been managed well with threatening of the bone ends and bone grafting and replating. The other option that we use for sterilization of the tumor wound is using by the help of a liquid nitrogen. It can be done by 2 techniques. First is a free freezing method and second is a pedicle method. We will be having a look at both of them individually. So the advantage of liquid nitrogen or other modalities is that there is no special equipment required for this procedure. It has a superior osteoconductive and osteoinductive capacity that the proteins are spared and they're not denaturated. The attachment of the soft tissue, like insertion of the tendons and ligaments, are preserved and which can be later subsequently used for reconstruction. It has been reported that the specimen treated with liquid nitrogen has tumor immunogenicity, which initiates an immune response against the tumor cell in the body. Disadvantage of this procedure is that there can be a fracture during thawing during the procedure, and there can be also injury to the surrounding soft tissue because of the liquid nitrogen. They may show the fracture in the soft tissue component of the tumor while thawing of the specimen. So coming to the first type of liquid nitrogen treatment, in which a tumor is excised in an intercalary or a hemicortical fashion. This specimen is then denuded of its soft tissue, and the medullary canal of the specimen is reamed. Drill holes are made in the specimen to prevent a fracture. The specimen is then now completely submerged in liquid nitrogen for about 20 minutes. And after that, the specimen is kept in room air for about 15 minutes. And after that, it is submerged in a distilled water for about 15 minutes. Then the specimen is ready to be reimplanted inside the body. In this patient, we have used a custom-made plate to fix the bone. So here's another example of patient which we had done an intercalary section for distal femur osteosarcoma. This is the immediate post-op X-ray, and here is the X-ray of a long-term follow-up, which shows good union at the osteotomy site. So here is a 40-year-old female patient of perosteal osteosarcoma, in which yellow line marked as a tumor and red line denotes the plane of resection. We planned a navigation-based resection of the tumor, and the planes marked are the planes of the resection, and yellow is the tumor bone. So using the navigation technique, we did a hemicortical resection of the involved bone. It was then treated with liquid nitrogen and reimplanted. The advantage of this hemicortical type of resection is that it has a larger surface area and so has a higher chances of union. The second method of liquid nitrogen treatment is by doing a pedicle cryo. In this, only one part of osteotomy is done, another part of the osteotomy is spared. The whole limb is rotated and the tumor specimen is then submerged in liquid nitrogen and reimplanted back. The advantage of the procedure is that we have one less osteotomy to deal with. it takes lesser time as only one osteotomy is there to fix. It has higher chances of cryo injury because the cryo container is brought close to the patient and in the operative field. It is difficult to perform in a long distal femur tumors. So, procedure of a pedicle cryo treatment after clearing of the margins, the uh, bone is again re-draped in a fresh new drape. A K-wire marks the planned resection length, and extra 5 centimeter of the bone is denuded to prevent injury to the surrounding soft tissue. The tumor is then debulked from its soft tissue and then dipped for about 20 minutes by rotating the distal limb inside the liquid nitrogen. For 15 minutes, the specimen is allowed to thaw in room air, and for 15 minutes, it dipped in a distilled water solution. The bone is then ready to be reimplanted back, and you can see the distal osteotomy is spared, and only the posterior osteotomy is to be managed now. It has been fixed with a plate, and medial gastrocnemius flap has been done for the reconstruction. So other option is another example of pedicle cryo in which the proximal osteotomy was done, and in long-term follow-up it shows a good union. Osteoarticular cryo can also be done as just like ACRT, and we have seen good outcome with the osteoarticular resection cryotherapy. In a study by Shukia and all, 28 patient had and out of 28 patient, 23 had good to excellent outcome. 26 patient there was bony union at a mean period of 6 to 7 months. Complications were observed in 7 patients. 3 had deep infection, 2 fracture, and 2 local recurrences. The local recurrences that they observed were only in the soft tissue, not from the bone, and all these complications were managed successfully. The other option available is by pasteurization, in which the tumorous bone is treated at 60 to 65 degrees of temperature for about 40 minutes, and they then reimplanted back. Coming to the last option, here is a patient of 18-year-old male, osteosarcoma of the distal femur with a pathological fracture with huge contamination of the surrounding tissue. This only reconstruction that comes in mind can be an above knee amputation. But there is another biological reconstructive modality that we can be used for this patient is the rotationplasty. A rotationplasty is actually an intercalary resection of the involved bone, preserving the neurovascular bundle, followed by 180-degree rotation of the distal limb and fixation of the distal limb. Ankle functions as a knee joint in that when fitted with a modified below knee prosthesis. It is like equivalent of having a below knee amputation rather than a high above knee amputation. The prerequisites are there should be adequate plantar flexion strength, functionally ankle range of motion should be present, and the foot should be sensate. Vessel can be divided into an anastomose, but sciatic nerve should be present in rotationplasty. The advantage is that it solves the problem of limb length discrepancy and provides a wider margin. And there is no problem of phantom pain in this. The cosmetic appearance is the disadvantage of the procedure and has a negative psychological impact. Here is a patient of distal femur osteosarcoma. We managed with a type A1 rotationplasty, and long-term follow-up shows a good result. There is a video of a patient wearing a modified below knee prosthesis for a rotationplasty. So to conclude, there are factors that decide the reconstructive option in the patient. These factors are the age of the patient, cause of the defect, need or pre and post operative adjuvant, size and anatomical location of the defect, general health of the patient, his lifestyle and functional expectations, social and cultural issues, cost of the procedure, and the availability of the bone. So take home message is that a reconstruction option varies from patient to patient and should be individualized. Biological reconstruction options are durable and economical option for reconstruction. They are oncologically safe and provide a good functional outcome. Thank you. Hello.
Yes, great. Thanks, Rudra, for a nice presentation. Thanks, Rudra. So now in the second half, we looked at how patients' own sterilized tumor bone can be used. And I would like to ask Dr. Panchwag his experience on using ECRT and how and what can be the issues or the complications he has faced and how he's modified his technique of ECRT over the years to have good outcomes.
Well, the complications of ECRT could be sort of, you could classify them from disease perspective and the reconstruction part perspective. We will focus more on the reconstruction complications as of now. So the main problem with ECRT in a diaphyseal bone is basically the high chances of delayed union and non-union that occur at the diaphyseal end, that is the cortical end of the bone. Usually we don't face much of a non-union problem at the metaphyseal ends, but at the diaphysis, this is a really, really big issue. So some ways of reducing these particular complications is basically by using a very thin saw, as thin saw possible, so as to reduce the thermal necrosis. We use bone grafts at the corticotomy junctions so that we have better extracortical bone bridging as well. You have to understand that whenever the union occurs in an ECRT bone, a radiated bone, if this particular union is only at the ends, the entire vascularity will never get re-established throughout the entire medullary canal unless and until you are using a vascularized fibula along with that particular radiated bone. So these are certain things that we can sort of use. The other problems that we do face in ECRT reconstructions is the implant failure. So we have to always take care that we are using a good quality implant so that there are lesser and lesser chances of implant failure, implant breakage, and need of a reconstructive surgery. So these are basically some of the common things. We are also trying to sort of have, more of you can say a multiplanar type of an osteotomy so as to increase the surface contact and increase the surface area where the bones are in contact with each other so as to try and increase the healing rates. So that is something again that we are trying to do to reduce these particular complications. The other thing that we have noticed as a complication in ECRT bone is basically angular deformities and limb discrepancies. So this typically occurs when the bone, rather the growth plates are sacrificed, or we have a transfacial cut that has been taken so as to have an adequate margin. And you may have to sort of address these particular issues at a later date by doing a contralateral epiphysiodesis or maybe the ipsilateral limb lengthening. What is important is that you need to counsel the patients for that preoperatively itself, that you might require a procedure as such at a later date. A very typical complication that we have noticed in young patients again is kind of an angular deformity, which results, because of rather unequal growth at the adjoining growth plate. So that is something that we are still evaluating, but that is something again that you have to keep in mind and be ready to correct it if it is too much of an angular deformity. So these are some of the complications. Maybe use of a dual plate, a smaller plate on the other side may reduce the risk of non-union at the diaphyseal junction. That is another thing that we have been trying. And obviously resorption and failure if you have used cement inside the radiated bone is something else that we have had as a complication. So these are just some of the complications that we can sort of quickly think of.
Dr. Panchwag, do you always bone graft the diaphyseal site?
We actually do, but nowadays we do only the intramedullary part. If we are not going to use a vascularized fibula and if you are going to insert or inject cement in the medullary canal. So at least the intramedullary part, we sort of try and use a bone graft. And one of my modifications has been to have a longer periosteal sleeve on the vascular side, which we can sort of use to cover the junction or the osteotomy site, and we pack cancellous graft sort of under this particular periosteal sleeve. So this has also helped us in reducing our non-union and delayed union rates.
Okay. Do you always cement the medullary canal?
Well, it depends. It depends. We try and do a vascularized fibula whenever that's feasible. But if it's not feasible for any reason, then yes, cement would be one of our
That
choices.
was so. That was my next question. That do you rely only on ECRT bone, given the condition that the structural integrity is good and everything is fine? Do you rely only reconstructing the defects with only radiated bone, or do you always add a vascularized fibula to it? And what will be the indications if not in all cases?
Well, typically the cases that we choose for doing an extracorporeal radiotherapy and reimplantation are where the bone quality is reasonably good and reasonably maintained. If it's a very thinned out and sort of cortex which does not have any structural stability, now these are not the cases that we are going to be typically choosing for doing an ECRT. I will be using a vascularized fibula to add the biology to that reconstruct. Osteoinductive potential along with the osteoconductive potential to be precise. Uh, I would always cement if I'm not going to use a vascularized fibula because I don't want to rely only on the radiated graft because that is considered to be a weak graft and which may crumple or which may sort of resorb and then you're left with only the plate and screws that you have used for reconstruction and we have seen that these particular reconstructs fail over a longer duration of time. So if it's not a vascular fibula, I would prefer using cement.
Okay. So next question is the same. You are leading me to questions. And next question is, because we know that the at least the data from TMH says that the median union at diaphyseal osteotomy is 9 months approximately.
Yeah.
And we have seen that these reconstructions require very robust fixation. So do you rely on single plate fixation or do you augment it with a second plate?
Well, if possible, I don't span the entire length with the second plate, but I use it to, sort of have a very good fixation across the diaphyseal osteotomy site. So that is something that we do. Typically, what we have realized over the few cases that we have been doing is that if we are using a vascularized fibula, for example, it's very difficult to put in a dual plate because it might come in the way of the anastomosis, the vascular anastomosis. So those are the cases where we have not done a dual plating. In cases where we have used bone cement in the intramedullary canal, yes, that is possible. But what we do is typically we try to sort of telescope the bony ends. It is definitely possible at the metaphyseal aspect and put across two cross canceller screws or K-wires if the kid is or if the patient is too young. And at the proximal osteotomy side, we use a narrow DCP or a 3.5 DCP as might be required, along with the main implant that may have been used. So that is something what we do. We don't span the entire length. In our old cases where we had done only cementing along with the CRT bone, we have had implant failures, and those are the cases where we have spanned the entire length with dual plate, one lateral and one anterior, typically in a large bone like the femur. So that is also something that we have done, but yeah, those are a few number of cases. Typically, these problems will be lesser if you have used a pure vascular reconstruction or if you have used a vascularized graft along with the radiated bone.
Exactly. So these are the fine tips which you need to remember when you are doing reconstruction, a biological reconstruction with the radiated bone. It is going to take longer time. Your fixation has to be really robust, and you might require another augmentation at the diaphyseal site. Metaphyseal sites are not a big problem. They unite very well. In TMH series, we have seen that femur site, the bone site femur, gives you the maximum number of issues. In the initial part of the study, we were expecting that because tibia is a superficial bone, not much soft tissues left around it, but tibia unites pretty okay, but femur gives more issues. In the other part of the series, we used to bone graft these defects, but now we have seen that adding either allo bone graft or a demineralized bone matrix in the intramedullary canal doesn't help much. as Dr. Panchwag said, doing oblique osteotomy or a step cut osteotomy may increase the chances, but I think that needs to be reviewed, and these cases needs to be compared. Now, I would also like to add few points on cryotherapy, that is liquid nitrogen. This is becoming pretty popular, popularized by the Japanese group. Professor Suchiya has a couple of publications of long-term results. What is very important to see is that the union rates were pretty good in their series consistently, and that is the reason that from past about 18 months we are switching to more of cryotherapy. And it is not just for the pedicle cryotherapy, but also for intracalary as well. And we will definitely share our early experience with you guys once we have adequate follow-up on these patients. To further, I will also touch upon few other techniques, but before that, Dr. Srinath is again reminding me again and again that in the chat group you have a link of a survey monkey, which we are doing a survey which talks about how we should modify our practice during COVID. I'll request each and every one of you to please take this survey. We are concluding the survey tomorrow. So if you can take this survey, it will be a good data. And eventually it will help all of us, and we'll share results with you maybe in the next few classes to come. So we will request you to take this survey. Now, Rudra also explained about few more techniques like pasteurization and doing microwave. So we did a clinical trial on using pasteurization bone to reconstruct these defects. It had two parts, preclinical and clinical part. In preclinical part, we ensure that the tumor kill was adequate by pasteurization, and we did that by looking under the microscope for the viable tissue, and also by inoculation into the mice. And we found that pasteurization is a good technique which can kill the whole tumor cells, the entire set of tumor cells. And these it's a good technique which can be used to sterilize the bone. And then the second clinical part was to see what is the osteoinductive capacity of that bone which remains. So we saw that pasteurization can be done easily. It reduces the time because you are doing pasteurization in OR itself, and you have a pasteurizer in the OR, and you pasteurize the bone in the OR. So the time taken for to and fro transfer to the radiation unit is not, and hence we can we can complete pasteurization pretty early as compared to ECRT. But we found that pasteurized bone they tend to behave a bit weaker than the ECRT bone, and especially at the metaphyseal sites, we found in couple of cases the collapse of the bone. So we feel that the osteoinduction is okay, but osteoconductive property of the strength of the bone is not that great after pasteurization. So it's not very popular way of reconstruction, at least in our hands. So this is about pasteurization. Microwave we have not done, and most of the people have shown that microwave really denatures the bone, and both osteoinductive and osteoconductive properties are not great. A last point on rotationplasty, we also include rotationplasty in this presentation because that is again also considered as a sort of biological reconstruction. Though it is not a conventional limb salvage procedure, but it is much better than doing high amputations. And here bone-to-bone union can give you a single procedure which can sustain over the life of the patients and has fantastic results. And in the end, Rudra, if you can share your screen and can go back to the slide where we are discussing the factors which are assessing the type of reconstruction to be adopted. So maybe we can have elaboration of few points on that. Yes. Yes. So these are the various factors which helps you to decide what is the best method of reconstruction for each particular patient. you need to consider age of the patient. Like for example, if the patients are younger, then maybe you can use only patient sterilized to tumor bone because their osteoinductive properties are much higher. You also need to see what is the cause of the defect. What exactly we mean is what is the etiology. So in giant cell tumor, because we do not have any adjuvant therapies like radiotherapy or chemotherapy, the rate of unions are pretty high. So you may do away without vascularized fibula, and these may have high union rate, while the patients who are on chemotherapy and radiotherapy may have issues, so that can help you to take care of the debt. We also need to understand the size and the anatomical location. Size, so typically if your defect is less than 10 centimeters or 8 centimeters, you can actually use a non-vascularized fibula, but any defect more than 10 centimeters, usually you need to augment them with a vascularized fibula. And if it is upper limb, then only a vascularized fibula is good enough. But in lower limbs, in weight-bearing bones, you should augment it with an addition of allograft or a tumor sterilized bone, so that it has good strength and osteoconductive property as well. Obviously, these biological sort of reconstruction should be avoided in very elderly patient where the osteoinduction rates are less, and you might face issues with the union. Also, you want to mobilize these patients pretty early, and hence you can do non-biological sort of reconstruction in these patients. And again, not to forget what are the patient's expectation depending upon their functional expectations, and what is the availability or your infrastructure, the resources which are available to you. So if you do not have radiation facilities, maybe you can try cryotherapy. If you don't have liquid nitrogen, then, or if you have radiation, you should do that. If you do not have facilities of a vascular surgeon with you, then you need to keep that in mind. So all these factors will make you to understand and choose the right method of reconstruction for a particular case. So I think that's about biological reconstruction. It's about an hour, 15 minutes, and I think we've almost covered everything. Dr. Panchwag, any final comments, or if you feel we need to add anything?
No, I think that was nicely summarized. Most of the points have been covered. If there are any questions from the participants, we could take those quickly.
Srinath, any questions?
Nice, sir. It was pretty.
Great. So I think that's the end of today's session. And as usual, I would like to thank all of you.
Almost all the topics were covered.
What is the question? Can you please repeat the question?
Well, you could type it in the chat also.
Yeah. Maybe we can sort it when it comes. So once again, I would like to thank all of you to joining us in this class. Hopefully it was useful. And I would like to thank Dr. Rudra for making a nice presentation, and my entire team, including Dr. Srinath, Harsha, and Ashwin, for putting things together and making all this happen. Special thanks to Dr. Yogesh Panchwag, who has been a very big support for TMH Ortho-Onco classes, as he's always been there as our external expert, and he adds to a lot of experience and his inputs on all the classes. So thank you once again, and we will meet you soon again for furthermore classes. We shall share the details on the same groups as well. Take care, be safe, stay home.
Thank you.
Thanks, Yogesh.